In this video, I'll be talking about arthroscopic shoulder stabilisation. I hope it'll help patients understand the process. Arthroscopy is keyhole surgery. It's usually performed under general anaesthetic, meaning asleep. An additional local anaesthetic nerve block may be used. The patient is then carefully positioned on a special operating table. Several small incisions are made and a camera and other instruments are then inserted into the shoulder. Visualization is improved by running fluid into the shoulder. The shoulder or glenohumeral joint is a joint between the humerus or arm bone and the glenoid, which is part of the scapula or shoulder blade. The glenohumeral joint is surrounded by a sleeve of tissue called the capsule. The shallow glenoid is deepened by a rim of cartilage called the labrum, which is attached right away around the circumference of the glenoid socket. When a shoulder dislocates, the capsule, labrum and humeral head are all injured. It's easiest to understand this if we imagine looking at the glenohumeral joint from below. In this position, the ball of the humeral head sits on the socket of the glenoid, rather like a golf ball sitting on a golf tee. The labrum, pictured in blue here, is attached to the edge of the glenoid, and the capsule in red surrounds the joint. When a shoulder dislocates, the humeral head usually moves forwards or anteriorly. The labrum and capsule are stripped from the front edge of the glenoid, and the back of the humeral head comes to rest on the front corner of the glenoid socket. This part of the humerus is very soft, and an impression fracture or Hill-Sachs lesion is created. When the shoulder is put back into joint, the capsule and the labrum stay detached, and the impression fracture remains. This causes a predisposition to recurrent dislocations of the shoulder. During arthroscopic shoulder stabilization, the camera is first placed into the shoulder joint from behind. In this picture, the humeral head can be seen to the right, and the glenoid with the surrounding labrum to the left. In this picture, the labrum is normal. In this picture of a different shoulder, the labral detachment can easily be seen. The labral tear is then assessed. This tear extends from low down at the front of the glenoid all the way up to the top. The labrum is freed up from the glenoid. Loose edges are trimmed and the glenoid is lightly burred to create a good surface for healing. At this point, we check that the capsule and labrum can be brought back into their normal position. We then use a special instrument to pass the suture through the capsule and labrum. This blue suture is then exchanged for a white permanent suture, which is passed through the eyelet of an anchor outside the body. A socket for the anchor is drilled in the glenoid. The eyelet of the anchor with the attached white suture material is placed into the socket. The suture material is then sequentially tightened to draw up the labrum into its normal position. And the suture material is fixed in place by punching the remainder of the anchor into the socket. This process is repeated with further anchors all the way around the edge of the tear. At the end of the repair, we can see that the labrum is now firmly attached.